Complicated Myocardial Infarction and Cardiogenic Shock by LaShawn Austin, Christine Brennan, and Jessa Villamor. Myocardial infarction, also referred to as acute MI, is the rapid development of ischemia and myocardial necrosis due to an inadequate supply of oxygen. Patients with non-ST segment elevation myocardial infarction commonly have ST and T wave changes on a 12-lead ECG, which indicates myocardial necrosis. Primarily, cardiac enzymes may be normal but may also elevate over the next 3 to 12 hours. Patients with ST elevation myocardial infarction commonly have ST elevation in 2 contiguous leads on a 12-lead ECG, which indicates myocardial infarction or necrosis. Cardiogenic shock occurs when the heart's ability to pump blood is impaired and the supply of oxygen to the heart and other body tissues is compromised. Left ventricular systolic dysfunction is the most common coronary cause of cardiogenic shock, most often associated with acute MI. Cardiogenic shock secondary to left ventricular systolic dysfunction is the most common cause of death in patients hospitalized for acute myocardial infarction. Although cardiogenic shock etiology is most likely to be coronary, there are also non-coronary causes in about 20% of patients. Non-coronary causes of cardiogenic shock include chronic heart failure, conditions that impair myocardial function such as dysrhythmias, valvular incompetence or stenosis, cardiac tamponade, and cardiomyopathy, or processes that stress the myocardium such as tension pneumothorax, severe hypoxemia, and hypoglycemia. Although cardiogenic shock is rare, it is often fatal if not treated immediately. On the other hand, about half of the people who develop this condition survive if treated immediately. Non-STEMI is typically caused by coronary vasospasm, most likely in people with high cholesterol and hypertension, accompanied by tobacco use, exposure to cold, extreme emotional stress, and use of illicit stimulant drugs, such as amphetamines and cocaine. Other causes of non-STEMI include spontaneous dissection and sluggish blood flow due to narrowing of the coronary artery. STEMI, on the other hand, is directly associated with the rupture of the fibrous atherosclerotic plaque, which then leads to platelet aggregation and formation of thrombus at the rupture site. It is then a medical emergency when the thrombus causes an abrupt 100% occlusion to the coronary artery, and this requires immediate revascularization of the blocked coronary artery. Risk factors for cardiogenic shock include older age, female sex, history of acute MI or heart failure, hypertension, cerebrovascular or multivessel coronary artery disease, peripheral vascular disease, left bundle branch block, kidney insufficiency or failure, and diabetes mellitus type 2.
There are several ways to diagnose cardiac issues, specifically a complicated myocardial infarction. The common lab tests ordered are troponins T and I. Troponin is a myocardial muscle protein released into the bloodstream after the myocardial muscle has experienced injury. These markers are not seen in healthy patients, so it is a very reliable test for acute MI diagnosis or necrosis. Arterial blood gases, or ABGs, are used to determine hypoxemia, as well as pH levels to confirm metabolic acidosis. Lactic acid levels are drawn to determine the extent of anaerobic metabolism, acidosis, and cell death. A basic metabolic panel allows for electrolyte values to be assessed. Calcium, magnesium, and potassium are all needed in minute amounts and all work together to maintain normal cardiac function. Values too high or low can have devastating effects, causing dysrhythmias, cardiac arrest, and asystole. Urinary output is monitored. Decreased urinary output is seen during shock as a result of the RAA system to retain necessary fluid volume for tissue perfusion. Urinary output less than 30 mLs per hour is indicative of shock. Diagnostics for the myocardial infarction and cardiogenic shock. Electrocardiography, the common EKG, is a routine part of any cardiac exam and very reliable. MRI Many abnormalities can be detected via this non-invasive measure. CT scan. Cardiac computed tomography imaging is again non-invasive and detects things like calcium calculation. Cardiac catheterization, an invasive test that studies both sides of the heart. Electrophysiologic studies, again an invasive test where programmed electrical stimulation of the heart is used to cause and evaluate lethal dysrhythmias. Exercise electrocardiography, or commonly referred to as stress test. This assesses cardiovascular response to increased workload. Myocardial nuclear perfusion imaging. Radioactive transducer substances allow for abnormalities to be viewed, recorded, and evaluated. And of course, blood pressure monitoring. Blood pressure and mean arterial pressure are monitored and used to determine tissue perfusion. Signs and symptoms of a myocardial infarction include chest pain and discomfort, substernal pain that radiates to the left arm, jaw, back, shoulder, or abdomen. It usually occurs in the AM and without cause. It can be relieved by opioids and can last 30 minutes or more. Common signs and symptoms that can be accompanied are nausea, vomiting, diaphoresis, fear or anxiety, dysrhythmias, dyspnea and shortness of breath, fatigue, palpitations, epigastric distress, dizziness, and confusion. Signs and symptoms of cardiogenic shock include severe hypotension, rendering a systolic blood pressure less than 90 millimeters of mercury, a narrowing map or mean arterial pressure, tachycardia, tachypnea, poor tissue perfusion, cold, clammy skin, again, urinary output less than 0.5 milliliters per kilogram per hour, or more commonly, less than 30 mils per hour, agitation, and acidosis from low pH blood levels. Monitor and report signs and symptoms immediately. Early detection is key. Undiagnosed cardiogenic shock has a high mortality rate.
Treatment of myocardial infarction. Access airway, breathing, and circulation. Defibrillate as needed. Obtain the patient's vital signs. Notify the rapid response team for specific interventions. Obtain a 12-lead ECG within 10 minutes of report of chest pain. Administer oxygen therapy to maintain oxygen saturation greater than 95%. Administer nitrates, beta blockers, pain relief meds, and antiplatelet agents as ordered by the physician. Cardiogenic shock therapy. Administering drugs such as vasoconstrictors, inotropic agents, or drugs that enhance cardiac perfusion when volume loss is severe and the patient does not respond sufficiently to fluid replacement and blood products. Increasing venous return, improving cardiac contractility, and cardiac perfusion by dilating the coronary vessels will provide the likelihood of a full recovery from shock. Prevention of myocardial infarction and cardiogenic shock. Refrain from smoking. Limit cholesterol intake to less than 200 mg a day. Limit sodium intake to 1500 mg a day. Increase your physical activity. Have your blood pressure checked regularly. Manage your diabetes with your healthcare provider. Also, refrain from excessive alcohol consumption. Reduce excessive stress. Avoid severely restrictive or fad diets. Restrict intake of saturated fats, sweets, and cholesterol-rich foods, and refrain from using illicit drugs. NCLEX question 1. Which of the following blood tests is most indicative of cardiac damage? And the answer would be C, troponin 1. Levels rise rapidly and are detectable within 1 hour of myocardial injury. Troponin levels aren't detectable in people without cardiac injury. NCLEX question 2. A 60-year-old male client comes into the emergency department with complaints of crushing chest pain that radiates to his shoulder and left arm. The admitting diagnosis is acute myocardial infarction. Immediate admission orders include oxygen by nasal cannula at 4 liters a minute, blood work, chest x-ray, and ECG, and 2 milligrams of morphine given intravenously. The nurse should first, and the answer would be A, administer the morphine. Although obtaining the ECG, chest x-ray, and blood work are all important, the nurse's priority action would be to relieve the crushing chest pain. NCLEX question 3. A patient is being treated for cardiogenic shock. Which statement below best describes this condition? Select all that apply. A, the patient will experience an increase in cardiac output due to the increase in preload and afterload. B, the patient with this condition will experience decreased cardiac output and decreased tissue perfusion. C, the condition occurs because the heart has an inadequate blood volume to pump. And D, cardiogenic shock leads to pulmonary edema. The NCLEX question answer to number 3 is B. A patient with this condition will experience decreased cardiac output and decreased tissue perfusion. And D, cardiogenic shock leads to pulmonary edema. Thank you for your attention.